So we're showing a couple of cases, one of acute Lisfranc's and the other of chronic neglected Lisfranc's fracture dislocation. If we have this kind of an X-ray presentation, this is one of our physiotherapists, which we saw about 3 years ago, I believe. You can see that gap between the bases of the first and the second metatarsals with a small fleck of bone there. Now, generally, in a general orthopedic surgery center, probably this would be treated conservatively. And when we advised surgery to this physiotherapist who was working for us in our own hospital, he ran away for about 2 weeks. So he did not believe that he needed surgery. He went around, consulted a few people. Everybody advised, "Isme kuch nahi hai. There is nothing in this, and you can just apply a plaster." So there was a plantar ecchymosis, which persisted for about 2 weeks. He didn't come to work, and then eventually, when the pain did not subside, then he eventually got the better thoughts and came to us for surgery. So whenever you have a plantar ecchymosis and a small fleck between the bases of the first and the second metatarsals, we must suspect Lisfranc's, and that gap means that it is an unstable injury. It's not only this, it is quite possible that the injury has started here and gone laterally and involved the bases of the second and the third metatarsal. So this could be unstable on the lateral side and even on the medial side. We don't know that unless we stress it and then we see it. And that is the X-ray, the CT scan. You can see the amount of comminution that you see in the area of the first and second metatarsals and the cuneiform. So those specks of bones on the plantar side are sure signs that there is a ligamentous disruption there. And this is a grossly unstable injury. Again, the flex sign is not to be missed. It could be so obvious here. This is not the same case that we were discussing about. But you can have major injuries. This is subtle injury, but you could have much more major injuries. And then I always say that if you have a Lisfranc's, you try to classify them. Then the ANC classification works well. And I say that it is an absolutely nobody cares. You don't have to classify these injuries, basically. What you have to do, but very important before you take these patients to surgery on your radiology, try and assess and identify which joints are involved, because it's like a bullet injury which enters at one joint, and depending on the velocity of injury, it can involve 1 joint, 2 joint, 3 joint, 4, 5. All 5 can go, and it can still be a closed injury. So we don't know what was the intensity of injury. So try and identify the joints which are involved and which have to be fixed before you go into surgery. Even then, you may have to go assess the stability of the other joints once you have fixed the obviously unstable joints on the injury. Also, you have to identify that is there a fracture which is affecting the joints, or it's a purely ligamentous injury, and is it reconstructible? Another important question. If it is a ligamentous injury, if there are major fractures which are fixable, then fine, you can go and open induction and internal fixation. If it is not reconstructible, then possibly a primary orthodesis is a good option. There is no role of conservative treatment in any Lisfranc injury which is demonstrated on an X-ray or radiology. There is no role. The only role of conservative treatment would be a completely stable injury which is suspected, and then on stressing it is completely stable. When those are uncommon injuries. So commonly the Lisfranc's are operative injuries. So ORIF is a gold standard, and we follow the principle of anatomic and rigid fixation of the first, second, and third TNT joints. There is a debate between primary fixation or primary fusion in many of these injuries now, but we won't go into the details of that. But still, the gold standard is rigid fixation of the medial 3 joints and non-rigid fixation of the lateral 2 joints. This is not the way. If we operate them and fix them, the K-wards is not the implant to use. It is rigid fixation of the medial 3 ray, either with screws or with plates, and non-rigid fixation on the lateral 2 rays. And Lisfranc's, we'll come to that. The direction of the Lisfranc's too, when you do an open induction internal fixation, is also a point of debate. Either way, the Lisfranc screw is from the base of the second metatarsal to the medial cuneiform or in the opposite direction. And the first direction has been shown to be, that is from the base of the second metatarsal to the medial cuneiform, has been shown to be a better screw from the point of view of insertion, as well as from the point of view of getting a good fixation. So we'll come to that case again. So this was our physiotherapist now on the OT table, finally consented to the surgery. So the incision will depend on how many rays you're fixing. So that is why it is important to identify, if possible, how many rays are unstable and where are the fractures involving. If you're fixing only medial 3 rays, then 1 incision on the second metatarsal is enough. And if you have to do an open reduction of more rays on lateral also, then 2 incisions, 1 on the medial side on the first web space and the other on the 4th metatarsal on the lateral side. So we'll go through this. Can you see my video? I hope it's not. Can you see?
Oh, yeah, yes, sir. Yes, sir. It's perfect. It's perfect. Very nice.
That's an incision on the first web space, and you identify the tendon of the extensor, hallucis brevis there, which has been retracted, and expose the first and the second TMT joint, the subperiosteal dissection there. In the first web space, we have to identify the neurovascular bundle and try and protect it. So that is the injury which has been exposed now, and this is the amount of instability that you see. Although we have exposed it on the dorsal side, if the plantar ligaments are intact, we will not be able to move these joints when we stress them. But here you can see how much movement is there in this unstable Lisfranc. So that is our physiotherapist. And then we did first the Lisfranc screw fixation. So a tenaculum is applied from the base of the second metatarsal to the medial cuneiform in the direction in which the Lisfranc screw is put. So that is the first keystone to be reduced when we are doing an open reduction and internal fixation. And then we put a Lisfranc screw. That is the first step in majority of the situation. And the direction of this screw is from the base of the second metatarsal in my hands towards the medial cuneiform. And once we have done that screw fixation, the stability has been achieved to a major extent. And then we can do, depending on the other areas involved, plate fixation, bridging plate fixation for the other joints. So this is a Lisfranc screw, and then we saw that the medial ray was pretty unstable. So we went on and did a cross plating, that is an X plate, with 1 screw in each corner of that unstable complex. The base of the first metatarsal, the medial cuneiform, the base of the second metatarsal, and the middle cuneiform. That's an AO plate which can be fixed to the bone using beaded wires, and it stabilizes the blade, and then 1 locking screw in each corner of that unstable complex to hold the injury together. Once we did this, we assessed the 3rd TMT, and to our surprise, we found the 3rd TMT was also unstable. So we went on and did a plate fixation of the 3rd torsometatarsal joint also in this patient. So these are the 4 screws in the 4 corners. These are locking variable angles going into different directions. And once we have fixed that, then we need to assess the other joints. So we were not expecting to find instability of the 3rd TMT, but when we went in, we did see a 3rd TMT. That is the 3rd TMT. See, that is the 3rd TMT instability. And then we put a plate on the 3rd TMT also. So that is how we fix this. And generally, if you have to do a lateral also, then you have to do a separate incision and only a K-wire fixation after open reduction of the lateral rays. So I hope we see the X-rays in the same video, post-op X-rays. So these are the post-op X-rays. This is on the table, obviously, 3rd TMT plate, Lisfranc screw, and a bridge plate across that unstable complex there. So this guy has not got his implant removed because this was not a fusion. This was an open reduction. 3 years down the line, he has not broken it. He has a bit of pain when he struggles a lot with a lot of walking. Then only, otherwise he's doing fairly well. Now that was an acute fixation. We quickly come around to the second case, which is a 29-year-old Delhi policeman who came to us with about 6 months down the line, but with these X-rays. So these were the X-rays on the day of injury. This is not the way he presented to us, but these were his X-rays on the day of injury, and it is obvious it is an instability of all the joints there. You can see the first is gone, second is gone, third is subluxated, and it looks like the 4th and the 5th are also a bit unstable. And somewhere in Delhi, this was the way it was fixed on the day of injury. So neither the joints are reduced nor the fixation is proper. Couple of KYs there. So And that is what you feel when you see that kind of case. And we call it an iatrogenic complication and God-made disaster, something like this. So it's a God-made disaster, but you can't do anything about it. And that is how you feel when you have that kind of fixation and you're going in to fix this kind of situation, that these are difficult. But then this was the X-ray at 6 months. Same patient, 6 months when he presented to us, unable to walk. You see the first TMT is unstable. The second is unstable. The third is definitely unstable. Maybe the fourth and fifth have been stabilized by the K-wire. Whatever was done, they were put back and they did not look. He was not having pain in the lateral side, but the medial 3 was very painful. And standing X-rays showed arch collapse on the lower bottom. On the lower X-ray, you see the subluxated TMT there. The first TMT, you can see the overhanging first base of the first metatarsal and collapse at the arch at this area, the TMT area. These are pre-op clinical pictures. On the right side, we can see complete loss, abduction of the foot there on that side, and valgus posture of the right side and pronation of the forefoot. So then we exposed, because we decided we are not going to do the lateral, anything on the lateral foretoes, one midline incision centered on the second metatarsal. So some nerves and veins, trying to preserve them. That is the tendon of the extensor hallucis brevis. Give an incision on the fascia of that tendon, exposing the tendon. This is also a step in the acute fixation. We retract the extensor hallucis brevis on either side to enter the joints, the first, the second, and the third TMT through one single incision. And many a times when you're doing a chronic case, you just cannot see the joints properly. So you have to remove the overlying osteophyte sometimes and bridging bone to see the joints properly. And we cannot do a fusion unless we have proper instrumentation. We have to distract these joints. So this is a hinterman's distractor with a wire at the base of the first metatarsal and one wire at the medial cuneiform. And then once you have fixed these wires and using the distractor and distract it, then you see the amount of joint that you can see. And unless we do that distraction, we just cannot do a proper job and the cartilage will not be removed appropriately. After the removal of cartilage, subchondral bone preparation is done with the help of drills. And once going back again, you see the subchondral preparation with drilling is very important. And once we have done that, we collapse it, remove the retractor and go on to the second joint. So this is a second TMT. Now again, the same distractor has been applied on the second TMT. And when we distract it, the similar situation, we will see the articular surface will be seen, the joint will be visualized using thin blade osteotomes or small curettes. We denuded the joint, subchondral bone drilling, and then the same step as in the acute phase. A Lisfranc clamp, tenaculum from the base of the second to the medial cuneiform, and then again a Lisfranc screw first to get the rays aligned well. That is a keystone where we generally start. You see this first is so much subluxated. Now that is a manual reduction of the first, and then after the Lisfranc screw, provisional stabilization with a wire, and then finally 3 plates again, first, second, and the third TMTs were fixed. And then these are the intraoperative pictures after finishing the surgery. And these are his post-op images. That's about 3 months, 4 months down the line and united. And that is his video. If you can see that of his walking. He was not able to put weight before the surgery because of the amount of pain he had, and he had a good restoration of his arches. So I'll stop here. I think I've shown the technique in a whatever way that was possible.